Well, I want to thank everyone. It's a great opportunity to speak at the ZERO Prostate Cancer Summit over here. It's, the whole path for prostate cancer, it is, it's an experience, and it's something that, it goes with the whole family. Everyone experiences it. So from me, I have an uncle that has prostate cancer, so it hits home seeing how that's affected him over the last 20 years. But that's a good thing. I mean, with prostate cancer, it's a slower growing cancer, but just the options that are out there right now, they continue to expand. And today I'm just going to cover the imaging aspect, as well as a little bit of background, because it's really important to know, you know where you're diagnosed with prostate cancer. You want to, treat it as best as possible. You want to cure it. But what do we have at this time to actually pinpoint where it is in the body? So today we're going to discuss a little bit about the prostate cancer background, which I'm sure most of you are familiar with, but for those that have family members that may not have a complete understanding, hopefully we can kind of just give you the full spectrum of the landscape. We're going to talk about the prevalence, incidence, and mortality. And then we'll go through from initial diagnosis all the way to biochemical recurrence. And then from the imaging side, we're going to discuss the imaging options that are out there. Molecular imaging or PET imaging, this is one of the key areas where we're best able to localize where the prostate cancer is within your body. And then I'll just highlight what we're doing at Blue Earth in this realm here. So this is all, I'm sure most of you are familiar with this, but 1 in 8 gentlemen will have experience or be diagnosed with prostate cancer in their lifetime. And this represents about 14% of new cancer diagnosis. And just last year alone, around 270,000 gentlemen were diagnosed with prostate cancer. Now, it's one thing to be diagnosed and you want to get treated, you want to cure this, but it's also important to know the likelihood of recurrence. So while being treated with a curative intent, even with that, about 40 to 50% of gentlemen will experience some kind of recurrence after initial treatment. And it's important to know where the disease in the body is, because when you look at the graph there on the right, the 5-year relative survival, when you can localize it, within the prostate or right around the prostate area, the 5-year survival is 100%. Once the disease becomes metastatic, this is where it becomes more challenging to maintain and try and treat the disease. And just last year alone, around 34,500 gentlemen actually passed away from prostate cancer. So what are the key risk factors? Several risk factors to be aware of is age. As gentlemen get older, you have a higher likelihood of being diagnosed with prostate cancer. When you're 40 years old, you have a less likelihood. But once you get above 50, the chance of getting prostate cancer increases. And out of about 60% of the newly diagnosed cases for prostate cancer were in gentlemen that were over 65. Race also plays a factor. So African American men and Caribbean men of African ancestry, they are more prevalent to getting prostate cancer, and they're almost twice as likely to die from prostate cancer. Dr. Poller, she kind of teed this up, but family history plays a role. So if you have someone in your family that's been diagnosed with prostate cancer, father, brother, you have a higher likelihood, your risk more than doubles to be diagnosed with prostate cancer. So, cancer is a very touchy subject, but it's important to, if you can communicate with your family members, if you're diagnosed with this, it's really important because others within your family may then have to go through the same matters. And then, as she also discussed, germline mutations. So BRCA2 is the big one in the room here, but the checkpoint inhibitor All these genetic germline mutations, they increase your risk of getting prostate cancer. So how does it typically present? You know, you're going for your annual checkup, the doctor's doing routine blood work, they're just doing, you know, just seeing how have you been for the past year. About 90% of diagnosis for prostate cancer happens at an annual screening, and most of it's through doing a PSA level. So when you're getting, you know, cholesterol checked, you know, making sure your kidney function's great, they do a PSA draw. Here's where 90% of these prostate cancers are detected just from a blood draw. Others, you know, if the doctor is going to do a digital rectal exam, so by feeling any kind of abnormalities, this is another way. Other things is when you're talking with the physician, being very honest as far as what's going on. So if you're experiencing any of these following symptoms, you know, frequent urination, especially at nighttime, difficulty with urination, weak interrupted flow of urine, painful burning with urination, erectile issues, ejaculation or blood and urine in the semen, communicate this with the doctors. The reason for this is, you know, they don't, you know, they want to get the full comprehensive picture so that if there is an issue, they can get you to a specialist to see what's going on. Because especially with these symptoms, this could mean you have more advanced disease. So as far as, you know, if you've had an initial screening and then you're going to talk to a urologist to see what's going on, this is where the doctor's going to get more clinical history to see, paint the full picture, what's going on with the gentleman, review the symptoms, do a physical examination, and they'll probably do one or more of the following tests, which is kind of, you know, maybe repeating what has previously been done, but they want to really confirm what's going on. So they may do another PSA blood draw, do another digital rectal exam, really trying to feel, is there any kind of abnormality, soft, hard areas, a lump within the, feeling around the prostate, seeing any kind of bumps that they could feel. And then biopsy. Tissue is really important. It's kind of the gold standard for prostate cancer diagnosis. You can get a transrectal ultrasound or MRI-guided biopsy. There's also, besides this truss biopsy, there's also a transperineal one, which may be, you know, there's always a risk for infection when you're getting samples, the method that you're getting the tissue. So there's other approaches that are now kind of being looked at and evaluated. But here, you're, with a typical biopsy, they're getting around 10 to 12 cores. So you're kind of just blindly targeting with just a regular truss biopsy. With the MR guided, you kind of have imaging to kind of guide the needle to try and get to where you think there may be some abnormalities. But still, maybe they get the tissue, maybe they just miss it. There's also what's called a saturation biopsy, where they may get 20 or more cores just to get a better feel for what's going on within the prostate. As far as the staging of a patient, so there's 3 stages. You could be localized, where the tumor is confined within the prostate, it hasn't spread. There's locally advanced prostate cancer. This is where the tumor has maybe extended just beyond the prostate, so within the seminal vesicles, the bladder neck, lymph nodes that are near the prostate. Now, metastatic disease, this is where it's spread to distant lymph nodes, as well as the most common area for metastatic disease is within the bone. And this just kind of reiterates what we discussed on the first slide here. So even with all the technological advances that we have, both surgical as well as with radiation therapy, the key is to try and have a curative intent for treatment for patients that you know, are eligible for that. But even with all these advances, there's still about 40 to 50% of patients that are going to have some kind of recurrence after their initial curative intent. And of that, basically a third of the patients that have biochemical recurrence, they'll have it within the first 10 years after initial treatment. And from the patients that actually have biochemical recurrence, a third of them will actually have metastatic disease. Now we'll get into my topic of imaging. Being a former imaging technologist, this is really important just so that, patient comes in, they're having these tests, but there's lots of questions. What is this test really doing? Is it gonna help the doctor? When I have a discussion with them for patient management, is this gonna help to kind of guide, the decision-making process? So with PET imaging, what PET is, it's an imaging modality, it's molecular imaging. You're injecting a radioisotope, a radiopharmaceutical, and this injection will circulate through the body, and each drug has a different mechanism of action. It'll circulate, the patient may circulate in an injection room, or they may have imaging done immediately on the camera. And from there, we're seeing where it's localizing within the body. Now, it's really important that me as an imaging specialist to educate the radiologist, because there's normal biodistribution for all these drugs, but it's really important to know where, what's considered abnormal, and knowing the thresholds to call something suspicious, or maybe that's just something that needs to be looked down the road. So we're going to talk about several of these imaging agents, and I'll kind of go in like chronological order as how they've been approved. So the most common imaging agent is fluorodeoxyglucose, or FDG. So what makes a drug radioactive? You have a radioisotope that's bound to a structure, and from there it gives this annihilation. So basically, with PET, it's positrons, and these positrons then hit these detectors on the scanner, and by where they hit on the camera, with all the computer technology, it can pinpoint where in the body that's actually coming from. So with FDG, it's labeled with F18, and with a radioactive isotope, they have, when it's administered into a patient, it's called activity. And each radioisotope has a specific half-life. So what does that mean? It means that the amount of activity that's injected, at a certain point, you have half of that material that's still remaining. So that's called the half-life. So for F18, it's 110 minutes. So roughly at 2 hours, whatever you injected, and even if it's not injected into the patient, it does naturally decay. So roughly, if you have 10 in the units millicuries, at 110 minutes after, you would have about 5. So FDG is most common in just oncology studies as far as other primary diseases. It's used for lung, colorectal, breast. It's used in cardiology now as well as neurology. But it's limited within the prostate setting. And the reason for this is that prostate cancer does not typically follow the glucose pathway. How FDG works is most cancer cells, they're glucose avid, so they want to use as much sugar as possible to divide and kind of replicate. So FDG would follow and get taken up by these GLUT transporters, and with that, they would sit in the cells. Because it's a synthetic sugar, it's not going to get incorporated, so it'll just sit in the cancer cells, and this is how the camera is able to pick up where the camera picks up where the cancer is. Now with prostate cancer, it doesn't follow that glucose pathway, so it's more follows a fatty acid pathway. So FDG has low sensitivity within the prostate cancer disease space. It also can have significant overlap with benign findings or inflammatory uptake. So when you're trying to differentiate, is this benign prostate hyperplasia or is this typical disease, it's hard to differentiate. And then looking at these images here, we see the normal biodistribution for FDG. So you'll have brain uptake. You also see how it's cleared through the body. So you have kidney uptake there, and that big hot spot in the lower portion is the bladder. So especially for prostate cancer patients, when you're trying to see what's going on, you have a very focal bladder that's kind of right smack in the middle of where the prostate would be, so it's hard to kind of distinguish what's going on. The next agent that was approved is sodium fluoride. Again, it's labeled with F18, so it has that 110-minute half-life. Now with this, the indication is for PET imaging of bone to define areas of altered osteogenic activity. Basically, they're looking for altered bone production. It's not commonly used. It was used infrequently, 10 years ago. More common, you gentlemen may know bone scans or technetium NDP. That's kind of been the standard of care for patients. But this is the PET option using sodium fluoride. Now, the one limitation is that with sodium fluoride, you're only able to see bone metastases. So you see with this example here, this patient has systemic bone mets. You don't know what's going on with any of the other visceral organs. So unfortunately, if you're looking to see, do I have liver metastases or something in the lung, you're not able to see this on this imaging tracer. Axumin, being from Blue Earth, this is our drug that we have a lot of information on. So Axumin, it's a different mechanism of action. So with this, Axumin is a synthetic leucine, and leucine is an essential amino acid, and amino acids are used for protein synthesis. So with Axumin, it will get taken up by these amino acid transporters, primarily LAT1 and ASCT2, and these amino acid transporters are upregulated in prostate cancer cells compared to the surrounding tissue. Now, Axumin is not specific for prostate cancer. Other primary cancers will have some amino acid pathways, but for prostate cancer, these are upregulated. And as with the other tracers, it does have a half-life of 110 minutes. And as you see with the normal biodistribution, you have minimal brain uptake, normal uptake within the heart, liver, pancreas. And one of the key benefits with Axumin is the low urinary excretion here. So especially when you're looking for local disease, you're typically not going to be compromised by any kind of urinary uptake. As far as the indication for Axumin, with Axumin, it's indicated for PET imaging with men with suspected prostate cancer recurrence based on elevated PSA levels following prior treatment. So it's not used within the initial setting. So as you see on this, we call it the roller coaster diagram here, men are diagnosed, they have some kind of treatment, and then unfortunately, they may have some rise in that PSA. When it becomes considered biochemical recurrence, this is where you can do an Axumin. And you can do it within several time points, both within the castrate-sensitive as well as the castrate-resistant population. So if they've failed multiple lines of treatment, you can do imaging once they have that rise in that PSA. As far as safety information, as with most tracers, imaging errors can occur. Having a negative image does not rule out prostate cancer recurrence. And this is because PSA is rising. Something's going on in the body. One thing with PET imaging, you're kind of limited by the resolution of the scanner. So if disease is below the camera resolution, I kind of call it like, use the example of like looking at TVs. So if you have like the latest and greatest of TVs, you're probably going to be able to see a little bit better. Whereas if you have a TV from like 20 years ago, you're not going to be able to kind of see as much disease. You're not going to have that all those fine pixels to see what's going on. And as far as the performance, as with other tracers, performance and detection rate can be affected by the PSA level. So as the PSA level rises, so does the overall detection rate. It's very well tolerated. Any kind of injectable can have a hypersensitivity reaction, but there have been 0 cases of any kind of anaphylactic events. Because every radio tracer is radioactive, it adds to the cumulative radiation exposure of the patient. And the most common symptoms or adverse events are injection site pain, redness, or dysgeusia, which is a fancy word for a patient having a weird taste in their mouth. So now we're going to move into a different mechanism of action. So we're going to talk about PSMA. So that's prostate-specific membrane antigen. And although it says it's prostate-specific, just like with Axumin, it's not specific. There's other cells that express this. It's called FOLH1. So this is why when you look at a normal biodistribution for a PSMA, you have uptake within the lacrimal glands, the salivary glands, liver, kidneys, and some bowel activity. So with gallium PSMA, it was the first FDA-approved tracer, and this was approved only at UCLA and UCSF in December of 2020. And the indication, it actually covers men with suspected metastases who are candidates for initial definitive therapy, as well as men in the recurrence space with elevated PSA. So it covers the initial as well as the biochemical setting. Now, gallium, it's a different radio tracer. It actually has a smaller or shorter half-life. It's 68 minutes. But the mechanism of action, the tracer itself binds onto this extracellular prostate-specific membrane antigen, and then from there it gets internalized. So once it's internalized, then with doing PET imaging, you can see where it's localized. With prostate cancer, most prostate cancer cells express PSMA, but there is a certain population that actually do not express PSMA. About 5 to 10% typically don't express PSMA initially, and this can increase as more treatments are kind of done on a patient. You can start having heterogeneity, so the expression can change over time. There was also, the first commercial kit was Telix, it was Illuccix, so that was actually approved by the FDA in December of 2021, and Locomets was the second kit. So this is just a way that the drug is made through the pharmacy. This kit was approved in March of 2022. Overall, even though there's two different kits that are made, the end product is still the same, gallium PSMA 11. And the indication, just like with the one produced by UCLA as well as Illuccix, they all have the same indication. Locomets, though, they actually have an additional indication, and it's for patient selection for metastatic prostate cancer for Pluvicto. And Pluvicto is basically the radioligand therapy. So, and this was incorporated with material from the VISION study. Polarify is another PSMA. The difference here is that it's got a slightly different structure, but it also is using F18, so it's got that 110-minute half-life. Again, it's got the same indication as what was from the UCLA, UCSF data, as well as with the Illuccix kit. It does not have the indication as far as for Pluvicto, but that's something that I'm sure is being evaluated. Same mechanism of action, so you're looking, you're binding to that PSMA, and from that, you're seeing where it goes within the body. As you see with this patient example, still, even with it being fluorinated, still has the same biodistribution within the normal organ structures. This one, however, this patient has metastatic disease, so you can clearly see with these hot spots where it is in the body. And with PSMA, it's really important also to know what's the normal biodistribution, because as with as Axumin and FDG, there are areas where it's just normal uptake. So that's why, as an educator, we try and make sure that the readers know what they're looking at, so they're not calling something that's not disease. And lastly here, just gonna talk about Pluvicto. So this was approved March of 2022. And this is it's a radioligand therapy. So just like the PSMAs, it binds onto that extracellular epitope, and from there, it's instead of it being bound to a diagnostic imaging like F18 or gallium, it's bound to a higher energy beta emitter. And what beta emission does, it actually causes single-strand DNA breakage. And with having that high energy, the hope is to basically stop the, basically to introduce cell death so that the prostate cancer will die. So with it binding there, it's kind of more of a targeted approach, and then you can use the diagnostic imaging to see where it is and have the therapeutic to just kind of tie in. And as far as with Blue Earth, what we're doing here, so we have Axumin that's approved within the biochemically recurrent space. We also are looking, because flucycline is not specific, we've wrapped up phase 3 for looking at brain metastases. And we also have a investigational drug, PSMA 7.3, that we've finished phase 3 testing for the initial as well as recurrent space. So we will have our own PSMA agent. And just like with Pluvicto, with our tracer, it's a radio hybrid, so it can be used both diagnostically as well as therapeutically. So we have that, and then we're also going into FAP. This is a different mechanism, but this looks at, it's kind of along the lines of FDG, looking at activation protein and maybe another agent down the road that could be used for prostate cancer. So I appreciate the time, and then I'm happy to take any questions. Yeah.
Are any of these new imaging modalities good for newly diagnosed patients to evaluate initial therapies such as hormone therapy, for example?
So the only approved agents for initial setting are basically the PSMA agents. So they can be incorporated. Since, with the Blue Earth not having that, I can't really speak on, what those agents they've looked at. But I know they're approved for the initial setting, and it's really up to the referrer and you to kind of have that discussion to see if it can be incorporated. I know standard of care has usually been MR, but it's slowly getting looked at more to see if it's going to help guide those the treatment. So.
And just a second question: do you anticipate that lutetium is going to move back earlier in the treatment process? Right now, it's given to people who are very, very seriously ill, but it seems that it might have the potential to work better if you move back where the patient is healthier.
Yeah, great question. That is being looked at right now. So I know Dr. Morgans yesterday kind of mentioned this, but the PSMA-4 and PSMA addition studies, they're looking at incorporating radioligand therapy earlier, but still they're still recruiting patients for these studies. It may benefit to have these treatments earlier on, but it's still, the data isn't all out there yet. So once they have that, then we'll be able to kind of have a better idea as far as the impact. And like Dr. Poller mentioned, see what the impact is on, how does it affect, overall survival.